Yeah, I just stopped. Okay. All right, I'm Alex. I think people are recognizing me, which is nice. So hopefully I'm not a new face. And you guys have either seen me around with patients or obviously through CQI. So it's not been long since our last one, but we're going to be going over some cases from February. There was less, I would say, for this past month, and so there's going to be a little bit more kind of like didactic, informational sorts of things. But we will go through several cases. And like every month, it seems like there's sort of some themes that tend to arise. Things tend to come in triplets in the ED. I don't know why, but there are several different cases of different types of ingestions. So we're going to talk about those to get started. Okay, so this first case, dispatched for a female that took Mucinex in an attempt to harm herself. On arrival, the patient was found with care of the engine, saying that she tried to commit suicide by overdosing on Mucinex. Patient's ABCs are intact, GCS is 15, she's alert and oriented ×4, states that she was trying to kill herself, and no other complaints noted during her secondary assessment, no procedures. Patient was transported to Children's Liberty on the cot. Status remained stable throughout the transport, and then care was transferred. This was a 15-year-old. Her vitals were blood pressure of 132/80, a heart rate of 94, a respiratory rate of 16, 97% on room air, and a GCS of 15. So pretty well-appearing kid, maybe like borderline tachycardia, but nothing super impressive in terms of like the medical aspect of her presentation. One thing to think about with cases like this is like what actually did the patient take and what could it have contained. So this is courtesy of the Mucinex website. It's a beautiful graphic. But like when someone says to me that they took Mucinex or they took some other like combo cold medicine or Dayquil or NyQuil, right? My first thought is exactly which one they took, because these medications can contain a whole host of actually potentially serious medications if ingested in the right quantity. Again, courtesy of the Mucinex website. This guy's disgusting, but anyway. So this is what some of these kind of combination medications contain. They don't all contain all of them, and some of them contain them at different concentrations, right? So acetaminophen, obviously, if taken an overdose, you guys all know that Tylenol overdose can be serious, if not fatal. Dextromethorphan can be serious in overdose. Guaifenesin, less so, but phenylephrine, diphenhydramine, all of these things can, if taken in the right content or in the right doses, be pretty serious and toxic. And so sort of the role from your guys' perspective, if you have any pill bottles on scene, if you have any, like, or the liquid ones, right? If you see any of that laying around, it's always super helpful to know exactly what was taken, because then we can actually look at the packaging, right? They may not know if it was the Mucinex DM or the cough or the cold or whatever it was. And so it can sometimes be hard to track down exactly what was in that like combo medication. Obviously, from a medical perspective, this kiddo was fine. They were just observed in the ER and then were admitted to inpatient psychiatry. So no like major issues in terms of that ingestion, but I thought it was helpful just to highlight some of the kind of like nuances, and this applies to all of the combination meds that are out there. All right. This next one is a 14-year-old, again. Oh yeah, absolutely.
The question always comes up with like the Children's Liberty versus like downtown versus Westchester or something like that. So both sounds are good, protecting fairway. Is there anything like presentation wise, even with like the Mucinex family ingestions, that would either say, oh, we should go downtown to base or Westchester, or even if things are kind of looking in like an anticholinergic or an acetaminophen toxicity, that like stabilization and children's transfer to Liberty if needed kind of situation, or is there anything more complex?
Yeah, I think Tylenol, like acetaminophen on its own, or if that was the main issue, the main component that you would worry about, there shouldn't be any issue with Liberty. Like we can get we can do full medical clearance, get the Tylenol levels, start N-acetylcysteine. The issue becomes mostly if the patient needs to be admitted to like ICU level care. But typically those patients are going to look pretty good initially after their presentation. So that person can probably go to Liberty, and then we can figure it out from there whether or not they need to go down to base. When you get to people who have more kind of serious manifestations of their intoxication, I think there becomes a risk benefit of like, are we gonna end up transporting them later? Well, that's fine, but if they're actively seizing on you then as a result of their ingestion or actively altered with a GCS of, 8, 9, 10, 11, we're not sure what direction this is going in. You probably don't want to spend all the time in the back of the ambulance taking that person down to base. So even if the definitive care is not going to be at Liberty, I think that person should probably still go to Liberty if they're looking pretty sick, so that, we can manage their airway, we can get stuff started, we can get antidotes started, all of that stuff.
Would time of ingestion dictate where you take them as well? Like say they took it 30 minutes, like they took a high dose of acetaminophen or the Mucinex DM. Would 30 minutes versus 3 hours dictate which location you would transport to?
Not necessarily. If we're half an hour off on obtaining a Tylenol level, we can still make pretty good decisions off of that. The hardest thing is if we have no idea the time of ingestion, that person ends up sitting around waiting for kind of repeat labs, no matter where they go. So same thing, we can rule out Tylenol ingestions pretty easily at either location, and then make a disposition decision, because only a small percentage of them are actually even going to need admission. And oftentimes it's to hospital, like to general hospital medicine before they go to inpatient psychiatry anyway.
If you have a pretty clear history, like, yeah, like the parents watched them take like 60 of these tabs or something, is there a precious like window that the patient's gonna like be protecting their airway, their hemodynamics before they crash? Which is to say, like, should that be the trip down I-75 before like intubated oppressors in the back of a
I think it depends on what you think they took. Because if it's something that's gonna act super quickly, like let's say like a calcium channel blocker, like that person took a calcium channel blocker very recently, like the answer is gonna be calcium. And the sooner they get the calcium, the better. So critical care transport after being seen at Liberty may still be the better option. And you don't know exactly when they're gonna crash. And so having that happen on your watch because you chose to take a longer, like half-hour transport, I mean, it won't be half-hour, lights and sirens hopefully, but depending on the time of day, right? Or where exactly they're coming from. I think I would still opt for probably closer. If there's major trauma associated, right? So like, yes, they took a whole bunch of Tylenol, but they also hanged themselves or they also jumped off something, then your disposition is going to be to Westchester for the trauma rather than to Liberty for the medical stuff. They're pretty good at putting those kids, like identifying those kids and putting them in medical rooms rather than like back in the psych area from the start. Like if someone is really medically ill from an ingestion, they're pretty good at like, I mean, you guys would tell us, but pretty good at identifying that early on, not just like they're like pulling them away in the back of the department. I'm sure you guys have brought patients to like that back section, right? Like they're people watching back there other than the 1 or 2 nurses. Is that helpful? I can always run it by Dr. Overman and see if he has other thoughts and just kind of follow up on if there's someone that he really would not want to come. But I think the biggest issue would be someone who's combo medical trauma. Cool. All right, so this patient, and I think this might be the Tylenol, so it might be good. No, this one's the different one. Okay, so this one was, and I didn't try to get all teenagers, but they all were. You actually had a couple of ingestions in older people as well. I just didn't think they were as interesting, but maybe that's my own personal bias. But this is a 14-year-old who was unconscious following an overdose. On arrival, the crew found the patient laying on her left side, being supported by her father. The patient was alert and oriented, covered in vomit. Father states that she took about 20 40 milligram fluoxetine pills. This is a serotonin reuptake inhibitor, antidepressant, and took the pills about 2 hours ago. He called her mom, who was a nurse, and said, just watch her. And if anything changes, call 911. The patient became lethargic and started vomiting. So that's when he called 911. The patient says that she is like able to respond and says that she feels very tired and can't stop vomiting. When asked why she took the pill, she said that she felt out of control, couldn't stop herself from taking them. She has a history of anxiety and depression, takes no other meds. In terms of assessment, again, found on her left side, alert-oriented ×4, ABCs intact, but was pale and vomiting. Her vitals were a blood pressure of 128/70, a heart rate of 97, a respiratory rate of 14, a SAT of 99 on room air, and a GCS of 15. She was carried out, placed in the back of the squad, and was feeling a little less nauseous. She was monitored, no issues. She's just feeling dizzy and weak. They did get a 3-lead and IV and gave Zofran and spoke to medical control at Children's, and basically said just continue kind of symptomatic care and call if anything else changed, and was transported to Children's Liberty, and report was given to staff. So this patient ended up being observed for 6 hours in the Liberty ED, and after that was medically cleared and admitted to inpatient psychiatry. This is a pretty risky ingestion, right? So I should have done the math before I got here. 800 milligrams? Did I do that right? 20 × 40? Like a pretty significant dose of an SSRI. And so the risks with that are serotonin syndrome, potentially seizures. Like this sort of change in her mental status is pretty concerning. But it seems like she didn't have any other kind of co-ingestions and basically was able to like get the med cleared out of her system in relatively short order. What we do when they show up to us is that we call poison control. You know, we have to immediately manage something, right? Immediately manage it, but we use them to really help us guide kind of observation time. And it's usually based on the half-life of the medication. Again, if there's anything else around that looks like there might have been more than one ingestion, like if someone took this and a whole bunch of Benadryl, that would change their obs period. So again, like what you're able to get from the scene can be potentially helpful in these situations. Lucky for her, she was able to kind of clear it and get medically cleared within that 6 to 8 hour period, and didn't have any major issues. If this was your partner calling you about your child's, which hopefully is never a situation, or a family member that calls you, just have them call poison control, right? Like you, from an EMS perspective and our protocols, we don't want you guys on scene calling poison control and making decisions based on that. But as a family member or a layperson, right, anyone can call poison control, and they probably would have gotten recommendations to just go ahead and go right in and not waste time kind of hanging out at home. There are plenty of times even that poison control will help kids stay at home or help anyone stay at home. So for children who drink a whole bottle of liquid Tylenol, they'll do like a per kilo dosing over the phone with the family and figure out what the max possible ingestion was. And some of those bottles are super small for a reason, and hopefully, and if it hasn't been too much, then sometimes they'll just let families stay at home because they know that the per kilo dosing of whatever it was that they took is not going to be toxic. So there are situations where poison control is not going to make people come in. In this situation, they for sure would have just told that father to bring this patient right in rather than waiting at home for, you know, potential badness. So if you're that nurse in this situation, just tell your family member to call poison control. 1-800-222-1222, anywhere, everywhere. But less of an interesting case, but we will talk about kind of like this class of medications again in a second. All right. The third case, again, dispatched for an overdose. On arrival, the patient was not found where they were dispatched to. Took a little bit of time and kind of were directed down the road. On arrival to the patient, their alert and oriented ×4, breathing normally, but appeared drowsy. They were able to ambulate themselves and get into the cot on their own. Said that she took about 10 milligram cetirizine pills, which is Zyrtec, an antihistamine, and an unknown amount of Tylenol. She stated that she took the pills due to a verbal altercation between her family members, and has a history of seasonal depression. And this was her first time taking many pills, so first time kind of doing this intentionally. She was also having some chest pain, rated about 7 out of 10, was placed on the monitors. 3-lead looked okay, and started going toward Children's Liberty. got an IV, got a blood glucose, and vitals were monitored. Her vitals were a blood pressure of 155/94, a heart rate of 116, a respiratory rate of 18, 98% on room air, a GCS of 15, and her glucose was 145. So in this scenario, the more dangerous of these two is the Tylenol, more so than the Zyrtec, which is the cetirizine. Other antihistamines like Benadryl, which is diphenhydramine, in this kind of dose would probably be worse than how much of the cetirizine that she took. But the Tylenol certainly, especially if you don't know how much or when, can be bad news. One thing to consider in this case, I mean, you had someone who had already admitted to 2 different ingestions and had some chest pain and tachycardia, so I would have gotten an EKG on this patient. When we're looking at EKGs for ingestion, and we're not looking for ischemic changes so much as their intervals and their QRS. So prolonged QT or widened QRS would be kind of 2 concerning findings in a case of an ingestion, and would push us toward thinking about other meds other than the 2 that she admitted to. So in a patient like this with, you know, at least one abnormal vital sign and a complaint of chest pain, I definitely would have gotten a 12 lead. This patient's Tylenol level at 4 hours was 112. And we basically have this like fancy graph that we refer to. And it starts at the 4-hour mark. If you look at the line kind of up here. So before 4 hours, we basically have no helpful kind of information about what a level means. So if we know the time of ingestion, we'll try and get that Tylenol level right at 4 hours, because then we can make an informed decision. If we don't know the time of ingestion, we basically get a random level and then usually end up repeating it depending on what the level is. If it's high, we just treat, but if it's low, we usually end up repeating it so that we have at least some sense of the direction of that patient's Tylenol level. So this patient was like 112, which is under the line, but not sort of insignificant. So she certainly did take a decent amount of Tylenol, but not enough to be toxic. And so she was able to be medically cleared and was able to go home after that. The other thing I forgot to mention with the second case, sorry, I'll go back here for a second. This patient also got Zofran, which is not unreasonable, but again, some of these ingestions can cause QT prolongation. And so getting an EKG before making that decision can be a good idea. You're unlikely to do too much harm with 4 milligrams of Zofran, but I always think about it before I give a potentially QT prolonging med in an ingestion scenario. So for both of these cases, an EKG might have been a good idea. Again, unlikely to give you actionable information, but it might have, you know, stopped you from giving Zofran in the first case, or could have identified like a whole separate issue or a separate ingestion for the last case. Questions about those cases? Cool. So this is just a reminder. I mean, you guys know this because you know who you see ingestions in and who you get called for. So there's kind of this bimodal peak in terms of ingestions. The first are stupid toddlers, and I can say that owning one of them, because they put stuff in their mouth that they're not supposed to and get into things that they're not supposed to get into, right? So these are unintentional ingestions, but they're actually the highest percentage of calls to poison control. I've called poison control twice about my own child. One of those silica packets that says do not eat.
Oh, yeah.
Turns out it says do not eat just because they're like an aspiration risk, not because they're actually toxic. So like, great. But then I had little silica balls literally all over my carpet that I was making up for days, which was very frustrating. And the second time he ate some sort of berry that could have been poisonous, but he only ate one, so it's fine. Everything's fine. I'm a great parent, guys. So this is your first peak, and these are usually unintentional. And then here's your teenagers and like early adult age people who are intentionally ingesting things with the intent of self-harm, right? So this all makes sense, but just a reminder that these are the people that you're going to see ingestions in. The dangerous ones, we talked about Tylenol. So the biggest risk with Tylenol is acute liver failure. And they can get very, very sick and have like abnormalities of their blood clotting and all this sort of stuff. Aspirin or salicylates is another one. They get kind of acid base abnormalities. The antihistamines like Benadryl will give you an anticholinergic toxidrome. So these patients are like febrile, everything's super dry, so like dry mouth, they're not sweating. They have mydriasis, so blurry, and end up having blurry vision because their pupils are big. And then they act super wacky and crazy, and can develop seizures, which get treated with benzos. But those antihistamines and the first generation ones, which typically is going to be Benadryl rather than the kind of newer ones like the Zyrtec type stuff, are going to be more dangerous. So certainly Benadryl, and again, Benadryl in combination with any other medication will slow the absorption or will slow the motility of the gut. And so when you would usually kind of like move those pills or that liquid through a little bit faster, if you've taken Benadryl in addition, it's going to kind of sit in your stomach longer and mean you're going to absorb more of it. So those patients have a higher toxicity and a longer time to clearing the medication. So it'll change how we treat those patients. Dextromethorphan, which is in some of those Mucinex products, can have respiratory depression. I don't need to talk to you guys about opiates. The antidepressants, so SSRIs or SNRIs, like the second patient, can lead to serotonin syndrome and seizures. The tricyclics can have major cardiac toxicity. So these patients get EKGs. It's one of the reasons we get EKGs right off the bat in basically any ingestion, so that we can look for signs potentially of this toxicity. And they get treated with basically like repeated doses of bicarb, sometimes a bicarb drip. So that's another patient where like time to getting bicarb is probably more important than getting them to, somewhere that can definitively admit them to the PICU. So another situation where probably going to Liberty is still the right choice. Benzodiazepines and barbiturates, obviously respiratory depression. Any of the cardiac meds I mentioned, calcium channel blockers briefly, but many of the cardiac meds can have significant toxicity. The oral hypoglycemic agents can lead to low blood sugar and seizures, and then insecticides, obviously their own kind of category. This is a list of medications that are on what we call a one pill can kill list. And so these are medications that if ingested by a small toddler can kill that patient with just one single tablet or one single dose. So these, again, a lot of this stuff, maybe not anti-malarials unless you're like planning a trip to Africa, but a lot of these medications are very, very common in the home. And so again, if you can find out exactly what it was, exactly what was in the pill box, exactly what was in the like unmarked, weekly pill planner, like whatever it is, as much information as you can get us in this sort of situation is helpful. So these tricyclic antidepressants come back up, antipsychotics come back up, the antiarrhythmics and calcium channel blockers. There's some weird stuff in here. So camphor is in Vicks VapoRub. So children that eat Vicks VapoRub or children that eat kind of like camphor oils that are sometimes used for for different religious, like not ceremonies, but I had a kid once who had it and because the parents had it for sort of like a stage or a little altar inside the home, that kind of thing. So sometimes there's camphor oil in that. Methyl salicylate is in those like arthritis creams. So arthritis creams, if a child decides to like grab onto that bottle and squeeze it and eat it, again, because they're not the smartest. Theophylline is less common. And then narcotics and the oral hypoglycemics, again, are super, super common and out there. So just as a list of things to kind of scare you. But in addition to the stuff that we think about with adults, these are particularly dangerous in toddlers. So what's the approach to ingestions? Step one is your ABCs, right? If they don't have a patent airway, it doesn't really matter what else you're gonna do. If they're not breathing, it doesn't really matter what else you're gonna do. So intervene on these first. Always get a blood glucose, and I would say pretty frequently consider getting an EKG. If you're like 5 minutes away and it seems like a low risk ingestion, I'm not gonna fight you, but for a couple of these cases, EKG may have been helpful, and we're always gonna get it every single time when they come into us. Assessing them for a toxidrome. So if you I mean, you guys know the opiate toxidrome really well, right? Pinpoint pupils, decreased respiratory drive. So if they have signs of another toxidrome that doesn't quite fit with what you were told, then definitely assessing for that. And then get as much information as you possibly can from the patient, from the scene, from the family or whoever's or friends, whoever's around the patient, or from the police. That information is stuff that after the fact, I have no access to any of it anymore, other than the family coming in and telling me something, where you guys are in a totally unique situation, like seeing the person where something happened or where they live, to be able to try and help us tease things apart. And if you can get a time of ingestion, it's always helpful. Obviously, we're gonna ask them again as well, but if it's someone that's like 3.5 to 4.5 hours on their Tylenol, right? I want to get in and get that lab sooner than a patient where it was half an hour ago. And so if you come in and give us that information, it's going to change how I triage kind of seeing those patients once they're in the ED. And then again, not for you guys to do on scene, but for you to remember for your family and friends, just knowing this number and always being willing to call it if you need to. Okay. Questions about ingestions? Okay.
I guess one other point about getting the 12 lead is if you get it and like it's a pretty strict, at least like TCA overdose, the QRS is pretty wide. I'd probably actually call ahead and see if they'd be okay giving you an amplified carb. I was just reminding myself of the protocol, and it's only in there for the PEA arrest protocol with suspected TCA overdose, but like if we can catch it before that with all the information we have, suspected or confirmed overdose, QRS is wide. I would 100% give it amplified carb if you ask on the way in.
So would you do it with a drip, or you just do like a push, like half amp?
I think for you coming in, I'd probably just give a bolus dose and then.
And that would just be directed by whatever medical direction that you call.
Yeah, at that point, unless it's a PA arrest, it would be outside the protocol, but I think it's very reasonable ask.
Yeah. And if you have a number and it's long, we literally treat the QRS number. And so if one dose brings it down, we just kind of like repeat. I've done like multiple boluses kind of in quick succession, and that person ends up on a drip, but we'll usually start with a bolus.
It's like
as well.
weight based for the child? Or?
It is, yeah, for peds it's weight based, and I have to look up like exactly what. But I think it's very like absolutely reasonable to call if you have a high suspicion and you have that data, especially if you're not 5 minutes away.
And same thing for like standard blood pressure, like hypertension medicines.
I think that
Like bowls of fluid or?
for hypotension, yeah, bolus of fluids. Yeah, I would treat hypotension like you would anyone else who's in shock, and bolus fluids. If it's as a result of a calcium channel blocker or other like antihypertensive medication, then there might be a specific antidote. But people are probably I would say probably less comfortable directing calcium administration in the field for that, unless they're in arrest, as opposed to bicarb for TCA. I don't know what you think.
Yeah, I was the same thing.
Yeah. If they're in arrest and you know that they took a calcium channel blocker, like that's the antidote is to overwhelm the calcium channel blocker with calcium. So I think in that situation, calling for that, it's a Hail Mary regardless, but it's the one thing that can help. Same thing with your end-stage renal disease patients who are hyperkalemic. It actually does do some good. So in that situation, I feel like medical control probably would be willing to authorize it. Otherwise, I would treat with fluids. In that situation. Yeah. It's tough because we have like a pretty small arsenal of true antidotes, right? And kind of knowing exactly what the patient took can be really tricky. I mean, we sometimes have kids like in the PICU on ECMO for weeks, and then eventually they wake up and tell us what they did, but like they, it's sometimes really difficult to get that information up front. Sometimes they've been stashing stuff for months. Like people are creative, remarkably creative, unfortunately. Okay. This is not an uplifting topic, but I think it's important to talk about. So I'm going to use a case that I don't know whether this patient was trafficked or not, but it is a patient who had a bunch of red flags, and so I think it's an opportunity to talk about human trafficking. If you don't think you've seen it, you probably have, and may not have recognized it in your patients, because patients are good at hiding things, or are not going to tell you up front that this is what's going on. But especially being on the highway corridor with lots of truck traffic, there is actually a decent amount of human trafficking in and around this area. So it's something that you need to be able to at least kind of have your spidey sense out for, even if you never know whether or not it truly was happening. So this is a long one, but I think it's worth going through. So this was a 16-year-old involved in a motor vehicle accident. When you question the patient, she says she's 16, she claims she's pregnant, and when asked how she knows, she says she's been feeling pregnant for over a year now, and the baby's late in developing. Okay, whatever. She admits to using cocaine, Percocet, and alcohol last night and today. And she was in this MVA while driving the vehicle with a 34-year-old male that she admits she's having sexual activity with, and states that the male was driving the vehicle in excess of 100 miles an hour when they came over a hill, lost control, tried to put the brake on and kind of careened off into an embankment, and rolled over, airbags deployed. She was the restrained passenger. So she hit her head and now has head pain. She says she's homeless, has had no prenatal care, and has no blood work or urine testing to verify that she's pregnant or not. On arrival, in terms of assessment, the patient's walking around in the police's custody. She was alert and oriented, but confused, and some conversation was mainly unclear in terms of like her story of how exactly the accident happened. The vehicle did not appear to have damage consistent with 100-mile-an-hour greater speed. It looked like more 35 to 45 miles an hour, because there was minor damage to the front side of the vehicle, and the vehicle had rolled over onto the passenger side. The patient had dilated pupils, but they were reactive to light, clear lung sounds, no obvious signs of trauma. Says that she does not have neck pain on palpation, or palpation of the back. Her abdomen, like the documentation is a little tricky here, right? Soft, tender abdomen with no seatbelt sign. So where's that tenderness? What exactly is going on is a little bit of a question to me. She's placed on the cot, C-spine checked, blood glucose was 107. Vitals were fine. I didn't write them down, but not interesting. And she had a 20 gauge put in her arm. And because she was 16, was determined that the best place to go was to Westchester. So monitored vitals en route and basically transferred care to Westchester. So in terms of dispo decision-making, absolutely appropriate to go to Westchester for kind of the trauma workup. And she did end up having kind of concern for maybe a little aortic dissection, like a little flap on her aorta, and ended up going from Westchester downtown to UC to talk to vascular surgery, and got monitored there. She stayed there for 3 days in the ER. Her dad refused to pick her up, and eventually she was then transferred to Children's, where she was admitted until the county could basically figure stuff out. She was discharged in county custody, and discharged to a group home. So a pretty sad story from a social perspective, and I want to kind of point out the things here that raise my suspicion for trafficking. So first of all, patient's 16, clearly seems to maybe have some sort of psychiatric stuff going on, although obviously not possible to diagnose that. But a 16-year-old with significant drug and alcohol use, a 16-year-old who's having sex with a 34-year-old, which is not legal, and kind of in this sort of high-risk situation of getting in a car wreck. And then on top of that, she's homeless, and once the conversation is had with whatever kind of adult human that's supposed to be taking care of her happens, clearly it's not a good home situation. So lots of things here that tell me that this 16-year-old may not be consenting to the entire situation. And to think about that and know about it, you kind of have to think through the definition of human trafficking. So human trafficking, sometimes called modern day slavery, is a crime that involves compelling or coercing a person to provide labor or services or engage in commercial sex acts. So it can include sexual exploitation, forced labor, trafficking for criminal activity, forced marriages, or other forms of coercion or exploitation for profit. And so the key here is really that somebody is trading or paying or otherwise coercing, i.e. holding something over someone's head in trade for whatever service that they're being trafficked for. So that's the key, is that the person doesn't necessarily want to do this stuff, but they feel like they have to. And that can be trading money or sex, or it can be trading housing, food, goods, or it can be withholding those things if the person doesn't perform the kind of like act that is being trafficked for. So sort of nuanced, but it's that coercion piece of thing that is the key when it comes to the definition of human trafficking. The situation's pretty bad. So a lot of people are victims of human trafficking. Globally, the most common is forced labor. But in North America, trafficking for sexual exploitation is the most common form of human trafficking. And then globally, there's a lot of individuals that are victims of forced marriages. Again, not the most common thing to happen in the US. Here in the US, there were 11,000 trafficking situations in 2019, almost half of which were minors. And this is information taken from the National Human Trafficking Hotline, which is actually a hotline that anyone, again, can call if they have concerns or kind of feel like there's some sort of suspicious activity going on. So it's important to realize that not everyone are going to be kids, right? So adults get trafficked as well. But there is a large percentage of patients that are going to be minors. And although you're not mandated reporters for the trafficking itself, if you suspect any kind of form of child abuse, which includes like rape or sexual abuse, then that is reportable, and you guys are mandated reporters from that perspective. So once it becomes a minor, if they're being forced to work without pay or work to be able to have housing or food, it's a little bit of a gray area. But if someone is being abused as part of their trafficking situation and they're a minor, then at that point it is reportable. So again, trafficking for sexual exploitation is the most common form of trafficking in North America. And there were over 7,000 reports of child sex trafficking in 2020, which is pretty horrific. In terms of identifying these patients, again, there's sort of red flags and risk factors that we can look at. And then there are demographics that can be helpful. The demographics do not include sex or kind of like wealth or their position in society. So boys and girls can be trafficked, but there are some other risk factors. So there's societal stuff. So the things that the position that patients are in. So for this patient, poverty and homelessness definitely are risk factors for trafficking. And again, it's because those patients are, it's more easy, right, to coerce someone into doing something for food or money if they don't have those things. And then there's some other just societal issues that are pervasive. Some other risk factors. Any history of abuse or neglect. So any individual that's been abused outside of the trafficking situation is higher risk for getting trafficked. Youth that are homeless or who have run away are higher risk for trafficking. They don't necessarily run away because of the trafficking situation, but they may be identified as an easy target by traffickers because they've run away or because they're homeless. LGBTQ youth are much higher risk for being trafficked. And then patients who have any kind of history in the juvenile justice or child welfare system are at higher risk for trafficking. There's some family issues that can kind of contribute, and there's community stuff. So immigrants are at risk certainly for labor trafficking, but also sexual exploitation, gang involvement. If there's any kind of resource issues within the community or a natural disaster that displaces people, all of these things put people at higher risk for being trafficked. The trafficker can be the sort of I think the person that people would usually talk about is someone who's like identifying this pimp as their uncle or their cousin or there's something who actually is not related to them, but they're calling them that. But you can actually be trafficked by family members, like real family members as well. So just because someone looks or seems or is acting like a parent or a guardian, that type of figure, doesn't mean that they can't be the trafficker. So just to recognize that it can be like random pimp on the street. It can be someone who maybe knows this person from some kind of like social context, or it can actually be a family member. And again, that money, those goods, those things that are coming in may not be serving the individual that's being trafficked and maybe being funneled into the family unit. Some of the stuff that we think about when kind of, or red flags that might indicate that a patient might have been trafficked. And these are not specific for trafficking, right? Like all of these things can happen to an individual for a variety of different reasons. But once you start building up red flags, then these are the patients that we kind of like flag and follow and report, basically. So if they have recurrent STIs, recurrent pregnancy, especially at a young age, if they have infertility or multiple abortions, especially at a young age, for patients that are in dangerous work conditions, they might have kind of chronic pain that you may not expect for their age. If they've been neglected, then we see people that are malnourished with bad dental problems or kind of progression of chronic disease that would normally be able to be cared for, like diabetes or cancer. Obviously, if patients are covered in bruises or scars, that's a pretty obvious thing, but you do have to go looking for it, right? And then tattoos, especially tattoos of somebody's name, gang symbols, or tattoos in weird locations. So sometimes people will have their pimp's tattooed on like the inside of the lip or any kind of like, or in any sort of sensitive area. Those would be tattoos that would raise my suspicion. If they are not allowed to seek care or are cared for unsafely or by untrained individuals, because one, people who are being trafficked may not trust the medical system, or two, their trafficker may not allow them to seek care for injuries sustained or illnesses sustained as a result of their trafficking. So they may be cared for inappropriately, or these things may go uncared for. And then loads of psychiatric kind of sequelae that are related to trafficking or may again be the thing that puts someone at risk for trafficking. And then specific physical exam findings. So clothing that's inappropriate for their age or their income. So sometimes you'll see younger teenage girls with like a lot of really nice stuff. Like everyone has $1,000 iPhone now, so that's sort of hard to like use as a gauge. But like really nice designer purse, lots of cash, really nice clothing for someone who is saying that they're homeless, right? That might be a sign that they're getting money from trafficking or some sort of illicit situation. In terms of their skin, again, tattoos in weird places or signs of injury. Can be pretty obvious, but they can also be hidden, right? So a lot of times people will maybe have their hoodie up or their shirt collar up and actively be hiding these things. And if you don't ask to remove that item of clothing or at least take it down or look up and down their arms, things like that, you may never find these things. And I'm not saying that you should expose every single patient out in the field, but if someone's being cagey and like won't take something off, they might be hiding something significant, especially from a traumatic perspective. From an HENT perspective, again, those tattoos on the inside of the mouth, really bad dental care. Again, with COVID, like everyone has terrible teeth at the moment, I feel like, so it's not specific to trafficking, but when you take it in the context of all these other things, can be a sign that person's not getting care, basically. Any kind of trauma to the chest or the abdomen, and then obviously like genital stuff, which we're not going to be looking at. So these are some of the things that we are thinking about. And again, the things that are going to flag us to report instances of human trafficking.
She was reported, it was my patient.
Yeah.
She was very hard to read initially. She was on some type of stimulant. She was all over the place with the story. As soon as I was able to kind of have a sense that I do think she's 16 and she did admit to sexual intercourse with the driver who was 34.
Yeah.
Who was also popped up on something. I called back, reported to the police that she admitted to being sexually intimate with that 34-year-old man that was on scene, so we kind of went that route.
Yeah.
We did initially, because her story was just so outlandish that like, she'd been pregnant for over a year, it was a slow developing pregnancy, I'm like.
Yeah.
Didn't make a lot of, like, maybe, so I called Children's initially just because of her age. They said absolutely not, take her to level 3, I'm like, I get that, I understand, I just wanted to touch bases.
Yeah.
And then Westchester, no problem, I reported all the same things to Westchester as well, so.
Yeah. And that's the key, right? So tell the people that are taking over care, again, what your concerns were.
I just want the cops and not let that dude go before
Yeah,
some of that stuff was made to light.
yeah, absolutely. No, really well done. And I think that's a very reasonable kind of route for you guys, because I think it's easy for us to say, like, EMS are mandated reporters, right? But to call the county and go through that process, like, I don't even have to do that in my job, so it seems unfair. Like our social work teams usually do all of that, so calling the cops, reporting it to the ER, or even like if you don't feel like you're getting the response you
I
want in the
requested
ER.
social worker at the.
Exactly, ask for the social worker in the ER, right, so that you've done your due diligence, so that's great. And again, the actual like, you know, if you are worried about trafficking, but you don't quite know what's going on, you can still report that, right? You don't have to have data, all you need is a suspicion. So if you're like, this doesn't seem right, or maybe the guy was 20, 24, and like, yes, technically the sex is still illegal, but like, there's less of a, it wasn't such a creepy story, I don't know, it's still creepy, but
I'm 6
Like-
months, it made my stomach crawl.
yeah, it's awful. So the point at like the most basic thing is that all you need is a suspicion. You do not need proof, you do not need data, you don't need to know who done it, you don't need any of that stuff. If you're worried about a minor, you can and should report. And so going to the cops and or making sure that you're actually touching base face to face with the social worker in the ED is a great way to do that. And again, you can report directly to the National Trafficking Hotline. You can call 421 KIDS yourself. These are all things that any lay person can do and that any medical provider who's a mandated reporter can do. But it's helpful to, it's like easier for us to kind of go through those formal channels. So I appreciate that you did all that. Yeah. Yeah, I had 2 back-to-back days this weekend where I had 12-year-olds having sex with 19-year-olds, and I just don't, anyway. Yeah. They think they can consent, but legally and obviously developmentally they can't. So it's really surprising how often this kind of stuff happens. And again, there's going to be plenty of patients that you and us are going to miss over our career that we're not going to identify that trafficking situation. When it comes to kind of like how to manage that, this is where your communication, your relationship building really are important, right? So it's hard if the patient is high or altered for any reason. But if they are able to kind of talk to you, are able to build that relationship, just making them feel safe, really doing your best not to be judgmental in any way, validate them and their emotions, and recognize that some of the behaviors are basically an adaptive response to the horrific situation that they're in. And when you're examining them, when you're evaluating them, give them choice, communicate with them, and keep shared decision making so that you're again not contributing to negative experiences. These are resources that are available for you guys and for patients. The National Human Trafficking Hotline information can be particularly helpful to just give to adult patients, especially if you're in a safe situation. So if you're, obviously we can't report adults as victims of child abuse because they're adults, but they can still be trafficked. It can still be in incredibly dangerous situations. So if you are able to get them apart from the person that they're with or the person that you might be you think might be the perpetrator, one thing that you can do is give them resources. They may not know that this stuff exists or that they are a victim of human trafficking, because it can be extremely deceptive, the way that people are coerced into things. So these are information that you can give to patients. And then if you're interested in finding out more information for yourself, there's some resources on the left there for providers. All right. Next thing.
I was
Yeah, please.
that last point, which is, especially the trafficker is very much gonna wanna stay with the person being trafficked for a variety of reasons. So one is, if you're able to separate them and have that conversation on the ride in, that could be the only time that they're separated, and that might be a critical juncture. The other point too is that, like, if they're being belligerent and, you know, they have to sit in the back, I mean, don't make yourself, you know, in the same situation, but make sure the back end is there. The other tough spot is, you know, not so much the sexual kind of piece of it, but you know, the forced labor, so language barrier can be a huge kind of weaponization kind of thing for the trafficker. And so, you know, they might say, oh, no, absolutely, I have to stay with them because I'm the only one who can translate. Like, you guys know,
language line.
yeah, absolutely. So you guys know, you get the language line, we have it. And so that is a huge, you know, Stockholm syndrome. So, yeah, Stockholm syndrome, I think. Yeah, so it is, you know, sometimes, you know, things are what they seem. And that, I think, is part of the real challenge here is that when it's not, like, this might be the one opportunity that those folks have to actually kind of get out of a modern day slavery.
Yeah, I think for the way sort of I frame this for myself is like my hope for myself and my own practice is that I think about this more than it's happening, right? Like if it doesn't cross your mind, if you don't think about it as a possibility, then you're never gonna identify it.
Yeah.
We do the same in terms of like working kids up for abuse, right? Like the hope is that we get a whole bunch of negative workups for the couple that we find, right? Because that means that we are looking and that we're paying attention to these things. So we have to check our own biases. You have to maintain that compassion for patients who are difficult to deal with, who don't seem to want your help, who don't want to tell you anything, who are being combative or resistant or refusing to cooperate, right? Like maintaining that compassion and checking your own bias is incredibly important in these situations. And, you know, again, it's impossible to catch all of this, but if you are thinking about it and if some of this kind of like list of stuff that might be suggestive in a patient who has some other weirdness to their history, if some of that triggers it for you, then definitely report it to the authorities. And that way you've done your part. And again, none of us are investigators, none of us are cops. Our job is not to figure out how or what happened, but we are the people assessing the patients.
Last minor point is that even though it's a national number, an 800 number, just like Poison Center, you call it, it gets routed to your local office or company. So you'll get in Ohio, somewhere or another. I don't know exactly the details, but
And like, depending on the patient's preference, right? Chatting can be helpful, but also their phone might be being checked and all this other stuff. So having lots of different ways that they can access help can be helpful too. All right, depressed enough? Okay. This is a little simpler, and I'm gonna sort of defer a little bit to Dr. Richards in terms of specifics about exactly what he wants you to do in some of these situations, but I wanted to highlight a couple of points about some pain control documentation that I saw. This is a 31-year-old female with left lower quadrant abdominal pain. She was found laying on the bathroom floor, alert and oriented. Started while she was eating dinner. Started as a bad cramp and then radiated to the lower back. She has a history of ovarian cysts and had similar pain, but today, when those were diagnosed, but today's pain is a lot worse. 10 out of 10 coming in waves. She like bailed out due to the pain, and her husband had to kind of help her to the ground. She did have an IUD removed last week due to issues with it. Because she'd been experiencing heavy bleeding since December, and so that's why it was removed. She describes the pain as severe period cramps and had noticed some strange discharge when she went to the bathroom. No loss of consciousness, but she is dizzy, weak, nauseous, although she hasn't vomited and she's in severe pain. She's moved to the cot, vitals assessed, that were stable, and got a 3 lead that was normal sinus. And the patient's blood glucose was 142. She had a 20 gauge and got 50 mics of fentanyl, followed by a normal saline flush. Pain went down to 9 out of 10. She was placed on N-Tidal with initial reading of 36, and got another dose of 50 mics of fentanyl, and pain went down to 5 out of 10, which was more manageable for her. The hospital was notified and went to Westchester. So a couple of things here in terms of like, one, the documentation and care, like assessing the patient's pain, treating it, and then being aggressive about treating it are fantastic. The use of N-Tidal and actually documenting like what the N-Tidal was when you got started is really, really excellent, right? So fentanyl obviously is going to depress your respiratory drive. If you're giving do you want them to do N-Tidal for any opiate? Or just a second
If
dose?
you can, yeah, that'd be great. I mean, if it's, someone who's like blowing a second out of their leg, you need them like 50 and they're not like, 50 pounds or something, they should be fine, but any intervention would be awesome if you're able to put on N-Tidal. There are very few patients or situations where I would say, don't do it.
Yeah, I think you guys are great about using the cannula with N-Tidal, even if you're not giving someone oxygen. But it is just such a helpful tool in terms of your assessment and to identify kind of early if there's any change in the patient's situation. Obviously, there's a lot of national attention when it comes to the issue of ketamine and that sort of stuff, and N-Tidal with opiates, ketamine, or your benzos is really important. And I agree, like having it on any patient who's getting even a dose of those medications can be important and is a safety thing for you, right? Just CYA basically, and will help you to better assess your patients. In terms of the sort of like possible issues for this patient, plenty of women with belly pain that you guys assess and evaluate. And there's the whole spectrum of sort of possibilities here, right? So don't usually have complications with an IUD being removed, but certainly with it being placed, you can have significant complications, even like perforation of the uterus. So that could have been one thing. The location of the pain, the fact that she has ovarian cysts, this could be ovarian torsion. The timing of the IUD being removed, it's less likely to be like an ectopic pregnancy or something like that. But all of those, in addition to any of the like standard acute intra-abdominal infectious causes, are all on the table. And so I would aggressively treat and manage this patient. If they're tachycardic or hypotensive, be aggressive about giving fluids, because there's a lot of things on the differential that could be bad news bears. Luckily for her, she had basically colitis, so like an infection of her colon after being worked up, and basically just needed pain control and symptomatic management. But again, good call out on kind of like why and how the pain was managed and actually putting on N-Tidal. This next one is a 72-year-old who was seen for injuries from a fall. On arrival, the patient was standing up with assistance from 2 family members. She had slipped on the ice and landed on her right hip, had no history of being on blood thinners, but did have osteoporosis, was maintaining her airway, was hypertensive, all other vitals were normal, a 10 out of 10 right hip pain, which decreased to 5 after ketamine. But every time anyone would touch her hip, which is not very nice that you did that, but no, I'm just kidding. Anytime someone touches her hip, the pain gets worse. And she's like, don't do that to me. She was moved to the cot, vitals, access, and all that kind of stuff was given, and then the dose of the ketamine noted. So appropriate management, again, this patient did not have N-Tidal, neither in the narrative nor in the kind of like interventions documented. So just think about it, especially like little old lady, not sure how she's going to respond to this, right? They metabolize these medications differently. Even if you're giving an appropriate dose, then definitely consider having N-Tidal. And then this one was dispatched to a nursing home for a fall. Nothing you guys have ever done before. On arrival, patients found laying in a bed in the nursing home after staff reported that she'd fallen 2 days ago. and had a confirmed right hip fracture. Nursing staff requested the patient be transported to Westchester for pain management. They'd been giving an increasing amount of methadone, increasing from 10 milligrams to 20 milligrams. Got the patient moved over, assessed the patient, and had normal baseline mentation. Gave 50 micrograms of fentanyl IM, no change in vital signs, as a result of the, pain medication administration, and transported to Westchester. So this is a patient, again, and title would be good to document and put on. But also this is probably a really good candidate for ketamine for a patient who's been being treated with methadone, which obviously is not acting the exact same way as the fentanyl, but is that same kind of category of medication. You may get yourselves better pain control and kind of get a better handle on this with ketamine. So this is actually a great candidate. And I think I mean, in my experience, you guys use ketamine decently frequently.
It
And
works so much better.
think of it as a good option.
The amount of doses that we give
Yeah.
for fentanyl versus ketamine, I see a much better reaction in pain and vital signs with ketamine.
Ketamine, yeah. It's it's a really fantastic option. I don't know kind of where the discussion will land, Dr. Richards, with ketamine for, kind of like agitation and stuff with this department, right? And at the moment, you guys are just using it for pain, so there's no kind of like question about dosing or concentration and all that sort of stuff, so it's relatively simple and really quite a safe medication to give. And in a situation like this, where someone is either on chronic narcotics or being treated with methadone for whatever, then having something other than an opiate might help you a little bit better. So just something to remember and consider. With ketamine, you can see respiratory depression, you can see laryngospasm, shouldn't really be happening with the doses that you're giving, but still something that you need to be paying attention to. And obviously some patients are going to dissociate a little bit, so they might start acting a little funky, depending, although patients with fentanyl sometimes act a little funky too. So, questions about pain meds?
Be mindful too, currently we're in a ketamine shortage. So a lot of places are having hard times getting concentration, any kind of concentration of ketamine. So just keep that in mind. Like if you get a drug bag by chance and it says no ketamine, it's because we don't have any. So that's just the problem that a lot of facilities are going through right now.
Yeah, good point. And I mean, obviously you have other options, but do what you think is best for the patient. I think Dr. Richards is on the same page of me in terms of like, be aggressive about managing pain, right? Someone with a broken extremity riding along the back of an ambulance, no matter how good of a driver you are, sometimes a little bouncy and a little uncomfortable. So checking their pain, reassessing their pain, being aggressive about it, but at the same time, monitoring, remonitoring, and paying close attention to vitals and their clinical status after doing that is important. Do you want to do the couple of like quasi stroke cases?
You can run through them and
Okay.
then, yep.
So I had to dig a little bit, honestly, for content. Like it was a pretty good month from my perspective. So hopefully the stuff that we went through was helpful. There were several like, is this seizure, is this not seizure, is this stroke, is this not stroke kind of cases. So I'll just highlight a couple of them. So this was a 67-year-old dispatched to a residence for a fall, and upon arrival, patient's just inside the door with the engine company. They've been on scene a little bit, and the patient was convulsing in a non-epileptic seizure-like activity. Blood glucose was 101. Patient had a history of stroke and seizures that developed as a result. It was moved from the cot to the ambulance. Vitals were taken, but were unsuccessful due to patient movement. 12 lead looked like sinus with occasional PVCs, and was hard to interpret again because of patient movement. Tried 2 IVs without success and was transported to Westchester. You documented that you did have to sort of like gently restrain the patient so they didn't kind of fall off the cot, but no like true restraints that were needed. So a good call to kind of put in what you needed to do and why. They, when giving a report to the hospital, did activate a stroke alert because of the patient's history of stroke. In terms of vitals, there was no blood pressure that could be obtained, as was documented. But then when they said that there was a manual blood pressure taken, I don't know if that was in the hospital or by us, but it wasn't, it didn't end up being documented. So if you are gonna take a manual pressure, make sure that it gets into either your narrative or into like your intervention side of things. Heart rate was 90, respiratory rate was 20, sets were 98, blood glucose was 101, that was documented, and GCS of 9. So the thing with this case, I think my main question or issue is just, describing non-epileptic seizure-like activity. If you really think that, and you're not gonna treat seizure-like activity, especially in like an old person with a history of stroke, where seizures certainly could be presentation of either a new stroke or evolving changes as a result of their old stroke. Document, why you think that is what I would say, right? Because it is like kind of all over the place, or because it's suppressible, or because when you lift their face over their head, it doesn't land and hit them in the face. Because they're sometimes redirectable or can like maintain tone sitting up on the cot, like whatever the thing is that points you in that direction, just document why. Because looking at her history, it is kind of a concerning history. When I got the outcomes from Dr. Richards and Lauren, these were non-epileptic spells, and that's how she was managed. But just recognize that you can kind of document that a little bit more specifically, and remember that in just reading through this and reading through the history, I was like, I don't know, could this have been real? Should we have treated this? And so it was still a question when I finished reading through the chart.
Yeah, I agree with that, even if it is like, it's clearly a seizure, or I think it is, like, even describing a little bit of like kind of what you see is actually not a bad idea, because and then in the handoff as well, because that can actually give, especially like the neurologist, eventually a little bit of a sense of like kind of where the direction is. Like, I even like end up having to do some of this, like when I'm talking to the neurologist on the phone for the ED. Especially if it's like on one side, or they were doing this kind of thing in advance, or this is kind of how they, look when the seizure got aborted, whatever it is, like, it actually is helpful to just kind of describe that a little bit. Even if we're all with this true seizure activity. Preserved consciousness during, kind of the activity, that's a really important thing to put down. If they have a prior history, and this is exactly like your other non-epileptic spell, that's, that'd be a good thing to put down too, so. But regardless, kind of describing is not a bad idea. As I said, I don't think anyone's gonna fault you for getting percent suspicion.
It didn't state in there on blood thinners.
I didn't see that, and that was the other thing I was gonna comment on, like old person fall, even if it's at a doctor's office. I mean, they were going to Westchester, probably we're gonna go there anyway, but the trauma component of this is also like, there's a couple of questions there. I think, oftentimes sort of my goal with reading through anyone's note is like, do I understand the thought process and like really what happened? And I think here there's like a couple of little gaps that really would have helped kind of clarify, like, how important did they think the fall was? How bad was the fall? Was there any potential that it could have been serious, like blood thinners, age, that kind of stuff? And then some more information about exactly what was observed would have given me just a better sense of like really what was happening on scene, and your thought process as well.
But what may be receptive behavior, especially difficulty speaking and understanding, it certainly does have a differential.
Yeah.
Running out, things talking about.
Yeah. I mean, the differential is still broad for sure.
Oh, yeah.
Cool. All right, this last one was an 85-year-old with trouble breathing, also at a doctor's office, hopefully not the same doctor. Doctor stated the patient's having trouble catching her breath. She's learn oriented, has history of anxiety, no chest pain. Blood sugar at the doctor's office was 81, gave her some orange juice and went up to 115. Patient's skin is pale and warm, she's alert and oriented ×4. Then the patient's family advised EMS they want to go to Bethesda Butler. You guys assisted her to the cot with her cane, secured her, and transported to the medic unit. Once in the medic unit, when asked the patient's address, she just kept repeating her birthday. Did the Cincinnati stroke scale, which was negative, which is fantastic, that was thought about and documented. Patient's not sure about the president, or where she is or the time, and doesn't know what day of the week it is. So despite the initial documentation of being like alert and oriented ×4 in the doctor's office, clearly they're getting a different sense of like what this patient's mental status really is. Got an IV placed on nasal cannula at 4. liters, and I forget what her stat was. It was 97% was documented in Revere. Blood sugar was 122, 12 lead was transmitted to Westchester. And EMS informed the patient and the family of the change in hospital location due to patient's condition. And basically went straight to the CT as a result of a stroke alert after that kind of initial, or the second kind of part of this evaluation. So a couple of things here, like really good evidence that the medics did not sort of just anchor on what was told to them by the physician, right? Like hypoxia on its own can make you look like this, but the patient wasn't like frankly hypoxic or in severe respiratory distress based on their assessment, but did have this change in mental status. So having stroke on the differential and deciding on your destination based on that, I think was really well done for this patient. And like the couple of interventions in terms of rechecking your blood sugar, putting them on oxygen, getting the 12 lead are all really well done. This patient was evaluated by neurology and thought that she might have had a TIA or like hypertensive emergency. Her blood pressure was 188 over 139, so it was a 1 abnormal vital sign. And basically had like a back and forth course over her hospitalization where she had some diarrhea, was treated for a UTI, was recommended that she get an MRI after the CAT scan to kind of like fully assess for any kind of neurologic injuries, and refused that. And then had several other things recommended during the hospital stay and ended up leaving the hospital against medical advice. So not sure exactly what was going on in this situation, but certainly some sort of acute neurologic issue is high on the list. And again, I commend you guys for noticing it, for documenting all of the things that are important as part of a stroke assessment, and for like making disposition decisions based on kind of your clinical acumen. So I think this was the right decision and well done, and just a good example of how patients change and evolve and why we need to keep kind of redoing our assessment. Trust but verify what was told to you by the first people that were on scene, redo things, recheck things, and keep reassessing. And that's it.
Any questions from the virtual folks? Or?
Downloaded that way with department.
Thank you.
All right,
Good.
thanks everyone.
You have the insight.